Assalamu alaikum. And thank you all for joining us in our 5th International Zahaimer Conference. We will continue in our first session under the title of Comprehension Review. We are really in organization committee happy this year in our 5th International Conference of Zahaimer to have a speaker from Kingdom of Saudi Arabia. Most of our speakers today and the next 2 days, they are from Saudi Arabia. They are high qualified with huge impact in taking care of our patient in Zahaimer in different variety of specialty: neurology, psychiatry, geriatric, nutrition, and extra. The next lecture is entitled of Scientific Development in Stem Cell and the latest study in invention of Alzheimer's disease according to the current trend in the best practice. Please welcome with me Dr. Heytham Al-Tayyib. He is well known from Jeddah. He joined us today. Dr. Heytham is Associate Professor in Neurology, Neuropsychiatry, and Neurophysiology, Clinical Neurophysiology. He is the President in the Saudi Neurology for the chapter of Cognitive and Behavioral Neurology. He's also the lead in the Mind and Brain Study Initiative in King Abdulaziz University. Please welcome with me Dr. Heytham.
Thank you very much. Assalamu alaikum wa rahmatullah. Shukran, Dr. Lay. Thank you for the invitation. Thank you for the organizers. It's really a privilege to be here and speak at the Alzheimer's Society conference. You know, Alzheimer's societies are typically strong driving forces everywhere in the world, and you guys are living up to the promise. So I was asked to speak about stem cells and other experimental therapies in Alzheimer's disease. So I'm going to try to do that and, you know, give you the my dumbed down clinician's version. So we'll see how it goes. These are some disclosures. I think the first point to make in the midst of this hype about experimental therapies and immunotherapies and disease modifying and so on is that we should not forget as clinicians our primary duties to patients and families, which is to first accurately diagnose, handhold, educate, and have a really global and comprehensive view of the patient and family needs. None of the experimental therapies replace any of the above. And it is important to keep in mind also the spectrum of interventions that are standard, proven, and available and impact our patients' and families' quality of life, including some of the non-pharmacologic ones that you see listed there and the standard pharmacologic ones as well. And a typical visit in my clinic does not end without discussing reasons for hope, all while making sure that we don't give false hope. So one wants to remain optimistic and scholarly and make sure not to provide any false hope, and at the same time provide avenues that are appropriate for each patient and family. So with those caveats in mind, I sort of, you know, how can you review experimental therapies in Alzheimer's disease in 20, 30 minutes? There are like a gazillion things to review. So I try to stick with things that may be disease modifying, things that have clinical data, things that may be novel or developing, and things that your patients in the clinic may ask you about. And that's the list of things there. You'll see immunotherapies are up there because I think most of us still consider them experimental therapies, even though they are approved by the US FDA. A couple of them are approved already by the US FDA. They are still very much experimental in my eyes. And these are some of the other ones with stem cells down there. But let's start with stem cells as per the committee's request. So stem cells are, as everyone knows, are these primordial undifferentiated cells that end up differentiating into any cell line, any more advanced cell line, or a few select cell lines depending on which stage of differentiation they are. They are present in the embryo. They can be harvested from the embryo or from the umbilical cord. They're also present in the adult and in specific niches. Specifically, the bone marrow has mesenchymal stem cells that function in replenishing cartilage, bone, and hematological cells, and so on. They can also be gotten from the adult by induction of mature cells back into stem cells. So you can make stem cells by at the bedside in the lab. They're also reprogrammable, so you can take a stem cell and program it to, say, for example, express a favorable ApoE genotype with a particular goal in mind. And if you look on the left side of the slide, you'll see the different types of stem cells: neural stem cells, bone marrow-derived mesenchymal stem cells, human umbilical cord mesenchymal stem cells, embryonic stem cells, and induced pluripotent stem cells. And most of research is currently focusing on the second and third, so bone marrow-derived mesenchymal stem cells and human umbilical cord-derived mesenchymal stem cells. And the reason for that is that they avoid a lot of the disadvantages of some of the other types. So neural stem cells obviously require invasive harvesting. They are not easy to survive in the new environment, et cetera, et cetera. And if you look at the pie chart on your right-hand side, you'll see the orange and gray representing the two types of stem cells that I've just mentioned. And you'll see the blue is neural stem cells, which were used a lot in preclinical studies. So how do stem cells, how may they work in Alzheimer's disease, in neurodegeneration in general? The initial thought is that, well, in these disorders, there's neuronal loss and atrophy, so it makes sense to replace lost neurons to mitigate the effects of the neurodegenerative disorder. Turns out that the most promising aspect of stem cell therapy is in the substances that they secrete. So their secretome includes neurotrophic and anti-inflammatory factors and anti-amyloid and tau anti-aggregant factors that we think may be beneficial in patients with Alzheimer's disease. As a matter of fact, currently the thought is that it would be great if we could use these secreted substances to provide cell-free therapy, so to provide these excretory vehicles to patients without having to transplant stem cells. So the thought is that these substances exert paracrine effects that antagonize neurodegeneration, brain atrophy, neuroinflammation, and the proteinopathies of neurodegenerative disorders, along with reducing oxidative stress. So what does a typical preclinical study look like? And you still have a lot of them rolling in because there's a lot still to figure out about how to take stem cells into the clinical field. It looks something like that. This is from a study where a transgenic mouse model that expresses amyloid and tau is taken and infused with, if you look at the top part, there are two types of therapies. MSC is mesenchymal stem cells, and NSC is neural stem cells. If you look at the lower part, the colorful parts is immunofluorescent staining of brain sections. So you'll see that the top row shows amyloid plaques in green and activated microglia in red. The second and third row are the treated sections with clearance of these plaques and reduction in activated microglia, more so in the mesenchymal stem cell row. And what they do is also that they put their mice through mazes and test locomotion, and there are certain paradigms that are thought to model the cognitive deficits in Alzheimer's disease, and they typically show an improvement in those cognitive equivalent tests. So much about that. Stem cells have moved into early phase, very early phase clinical trials. If you go into clinicaltrials.gov and put in stem cells and Alzheimer's disease, you'll get 35 hits. And this is their breakdown in this pie chart. You'll find a few completed, but not all with published data. You'll find that some are still recruiting, and then a whole bunch with really an unclear fate without, we don't really know what happened with these studies, which probably means that they didn't end up with coming up with anything promising. So let's go through a couple of these that are available. Kim and group in South Korea demonstrated that you can safely, stereotactically inject stem cells into the hippocampus. So they have a total of 9 patients here with 3 injections in the low dose group and 6 injections in the high dose group. And being a phase 1 trial, their goal was to demonstrate safety, and indeed there were no significant safety concerns with stereotactic injection of stem cells into the brains of Alzheimer's disease or these patients to speak of. They also demonstrated, the same group demonstrated that you can inject stem cells intracerebroventricularly. So they injected them into an Omayo reservoir connected with the cerebral ventricles, and they followed these patients for extended periods of time. And this is how the CSF of these patients looked like. You can see in the top left, the CSF white count increased with every, which there was a laser pointer, it increased with every injection and then came back down. And after the second injection, 4 weeks after that, it goes up and comes down and so on. And you can also see that with every injection, your total tau and phosphorylated tau and amyloid beta levels in the CSF also change with each injection in non-sustainable ways. The bottom row shows biomarkers for stem cells which also go up with each injection, demonstrating that the viability of stem cells after the injection. So what happened with these patients? You can really say very little about comparisons. There's no placebo group. There's a lot of dropout, especially in the low dose group. But you can see that there's not really something major that happens, and that's not one of the goals of this phase 1 trial anyways. But it is important to know what happened is that all of the patients had significant fever. 3 of them were febrile for extended days, had to be hospitalized for a couple of months, and this is one of the major potential limitations to think of when considering stem cell therapy, is that they seem to elicit an inflammatory response that can be severe in some patients, at least when injected intracerebroventricularly. So this is also listed in clinicaltrials.gov. This is an infusion of autologous adipose tissue-derived mesenchymal stem cells, which is another source of stem cells that you can tap on. And this is what you have in there. This is unpublished data, and you can't really say much about it. The side effects are listed there, nothing too serious, it seems. And you can't say much about the cognitive parameters that they used, but if anything, the people that received stem cells didn't do better than the placebo. Stem cells were also injected intrathecally in this 3-patient series. And this is another way to demonstrate what happens in the brain when stem cells are injected. This is the FDG PET scan of some of these patients showing hypometabolism in the top row that reverses or is corrected, at least partially, in the bottom row. And this paper demonstrates some improvement in the cognitive parameters that they use. So this is another potential effect of injecting stem cells intrathecally. This effect, however, is not sustained, the improvement in cerebral glucose metabolism. Of interest currently is Lamosil B, which is passed through the phase 1 trial. It's an off-the-shelf donor, bone marrow donor derived mesenchymal stem cells that is given through IV infusions. And again, the goal here was to demonstrate safety. And you have 8 people that got placebo, 15 that got the low dose as such, and 10 people that got the high dose, and with follow-up extending for up to 52 weeks. And you can see what happened to the cognitive parameters here. In box A, you'll see that maybe the group that got the low-dose Lomosal B did better on the mini-mental status, and then there in C, the quality of life measure as well. And you can see what happened in the biomarkers. You can see the favorable VEGF, interleukin-4, which are anti-inflammatory, essentially seem to do better in the treated Lomosal groups, especially the one VEGF for the high dose for the VEGF. And you can also note that hippocampal atrophy, if you look at the box to the right side of the screen, top right, bottom right, there is a reduction in, there's a reduction in hippocampal atrophy in people who received the high-dose Lomosal B infusions. So that's really the extent of it. So what do you make out of this? Obviously, there is a lot to know. We don't really know which stem cells. We don't know what dose. We don't know. We still have side effects to worry about. We are in phase 1. And despite all of that, actually, I guess it's probably a lot of our experience is that patients come to clinic and ask about stem cells. And I have a couple of patients that already got stem cells, went to other countries and got infusions and intranasal administration of stem cells. So it's actually one of the things that I talk to patients about and deter them from engaging in stem cell therapy at the moment, because it's very much experimental and not at all ready for prime time, and we need to wait, and they're going to wait for us. They're not going to become babies while we're waiting, so no concerns there. All right, so moving on from stem cells, we have the major newsworthy immunotherapies up there: aducanumab, lecanemab, which were US FDA approved, donanemab, for which we're waiting for the phase 3 trial results soon, gantenerumab, of which phase 3 trial failed. And then there are a few others in the pipeline, including amyloid antibodies, tau antibodies, another version of gantenerumab that is going to be attached to a vehicle that enhances its transport across the blood-brain barrier. But we're not going to talk about those. But we are inevitably going to hear about new mAb words that we try to get used to how to pronounce. This is from the aducanumab trial. All of these medications reduce, the amyloid antibodies reduce amyloid significantly. As you can see, you've seen some of this before, so we'll breeze through it. Aducanumab got approved controversially, even though it had one negative study with no difference in the CDR sum of boxes, their primary cognitive outcome, and another study, the eMERGE, that did show some improvement in the CDR sum of boxes, and this improvement was 0.39 points out of the 18-point CDR sum of boxes scale. And the major side effect of amyloid antibodies is amyloid-related imaging abnormalities, which come in the form of vasogenic edema with or without hemorrhages, so ARIA-E for edema and ARIA-H for hemorrhages, the latter being worse than the former. You can see that 24% of people on adu had ARIA and were symptomatic with headache, confusion, and nausea. The majority of people are not symptomatic, but having ARIA definitely complicates how you follow your patient and whether you stop the medication if ARIA is severe, especially with ARIA-H. And there's been at least one death that is reported that may be ARIA-related. You've seen this about lecanemab, the second famous kid in the block, with, again, clear clearance of amyloid and a little bit of difference on the CDR sum of boxes. And you can see the difference is 0.45, and there are benefits, also mild benefits in the secondary outcomes. And the side effects, in addition to ARIA, include infusion site reactions. And there's been a reported case of atypical cerebral hemorrhage associated with this person that was reported in the New England Journal, had a stroke, got TPA, and had these really unusual hemorrhages. And it is thought that having received lecanemab had something to do with it. So the jury is not out yet. We have one trial for lecanemab. We don't have a negative trial. There are a few trials that we're waiting for the results of, including 2 long-term extension trials, a trial in preclinical AD, and the dominantly inherited Alzheimer network cohort. Donanemab had really impressive results in the phase 2 trial and applied for approval just based on those in the US and got rejected because of the small number of patients. One of the interesting things I always like to highlight is that for a number of patients, donanemab cleared amyloid completely and tau, and therapy was stopped, and those biomarkers stayed low despite being off of the medication. And there was an improvement in our cognitive/functioning dementia severity measure that they used here, and an incidence of ARIA that is equivalent to what we've seen with other agents. And we're waiting for the Trailblazer 2, the phase 3 trial results. And the interesting thing that they have for this trial is that they are going to stratify patients according to their tau burden as well, excluding patients that do not have tau and looking carefully at patients that have intermediate tau burden and analyzing patients who have high tau burden who are maybe late in this disease course separately, which I think is a really good way to look at the disease. And the last point we'd like to highlight about immunotherapy is that the benefits are really not that impressive. They're better than, I suppose, anything that we had before in terms of disease modification, but they're not what we would consider necessarily meaningful. And when this was looked at, what is meaningful, we think that it is 1 to 3 points in the mini-mental status, 1 to 2 points in the clinical dementia rating, and if you remember, the benefits were all below 1 point in the trials that we mentioned. That's it about immunotherapies. Now just highlights about a few other things. Hydromethylthionine mesylate, HMTM for short, is a derivative of methylene blue. We've all heard about methylene blue being potentially tau anti-aggregant when we were doing our training, and it is available and people have used it, etc. And the major limiting factor for its further development was its side effects. So HMTM is a derivative of methylene blue without those side effects, and it's past phase 2. And phase 3 trial is ongoing, of which partial results were presented recently in the CTAD conference, showing benefits on the cognitive ADAS-Cog measure there. And it's an interesting trial for the reason also that they are including people with delayed start of acetylcholinesterase inhibitors and memantine. And it's perhaps our leading agent that targets tau. So we'll look forward to that. Semaglutide, the blockbuster anti-diabetic, anti-obesity medication, is making its way through the Alzheimer world as well. How so? Turns out that GLP-1 receptors present in the brain reduce insulin resistance, improve glucose metabolism in the brain, therefore reduce redox toxicity. And it was shown that diabetics on GLP-1 agonists have a later time or longer time to develop dementia, lower AD risk. And there are phase 3 trials ongoing for semaglutide in AD, which should be interesting to look for. Statins, which at some point I think should be put in the water, are also promising agents. There's an ongoing trial for statins solely for the purpose of Alzheimer's disease, irrespective of vascular risk factors. You can see a meta-analysis there, again, shows something similar to what we talked about in GLP-1 agonists, which is that people on statins are at a lower risk of dementia. Senolytic therapy is an interesting concept. We've often focused on the pathology and not on aging cells. Turns out that aging cells express substances and engage in biochemical pathways that are destined to cause apoptosis for the aging cells. But when excessive, they start to injure non-aging cells, therefore contributing to neurodegeneration. Dasatinib and quercetin are agents that are thought to inhibit or to hasten the apoptosis of aging cells, therefore reducing their effect on nearby healthy cells. And the STOMP-AD trial is a phase 2 trial evaluating the efficacy of the combination. Anti-seizure medications, wouldn't miss a chance to mention seizures. It's thought now that anti-seizure medications may be helpful in patients with Alzheimer's disease, and it's a hot topic in both epilepsy and behavioral neurology. And it makes sense, right? So part of Alzheimer pathology is synaptic dysfunction, neuronal network dysfunction, which are terms very often used in epilepsy, and proteinaceous depositions are thought to cause those and therefore potentially cause seizures, and seizures are also thought to contribute to impairment in biochemical pathways that may lead to deposition of amyloid and tau, so there's a bidirectional relationship between these two disorders. Levetiracetam was the first anti-seizure medication to be tried with some depth, and this trial was negative in terms of reaching its primary outcomes. However, there were some positive signal there with patients receiving levetiracetam performing better on naming and spatial navigation, although the primary outcomes were not reached, so we're waiting for further studies of anti-seizure medications. Neurostimulation is another area of interest. Direct current stimulation, so this is like a little bit of stimulation to the patient's head, transcranially on the scalp, 1 to 2 milliamperes, has been tried frequently over the few decades and was demonstrated to lead to transient cognitive benefits without long-term benefits demonstrated at this time. Transcranial magnetic stimulation, there's also some small trial level benefit. It is really not clear whether low frequency, high frequency is beneficial in Alzheimer's disease, if at all. So there are a lot of questions there. That's something that we may hear more about. Transcranial pulse stimulation, which is basically therapy of a shock wave, a mechanical wave transmitted through fluid. If you look there to the top right picture, transmitted transcranially through a probe. There's also a small level trial that ADAS-Cog over the long term, over a year, may be better with frequent protocols of transcranial pulse stimulation. Of interest also is photobiomodulation, using specific frequencies of light and or sound transmitted through a helmet, like that space-like helmet down there, and or through goggles. And the idea is that if you transmit those particular frequencies, you're going to be altering large-scale brain rhythms and therefore altering brain function favorably. Oops. Almost there. DBS has been tried in Alzheimer's disease. It's been a few years now since a trial of 40 patients receiving deep brain stimulation was done, and the data is still being looked at. If you look top right, you'll see FDG PET scans comparing DBS off and DBS on, with on causing an increase in a non-sustainable increase in glucose metabolism. You'll see that we do not have cognitive evidence, but we're still working out the target. Where do we stimulate and how do we stimulate it? So that is happening as well. And brain network therapeutics is creeping into neurology and psychiatry, and Alzheimer is no exception. Finally, the gut microbiome is also an area of interest. People talk about it a lot and ask about it. And the idea is that we think that there's a brain-gut axis where the population of organisms in your gut produces certain amino acids, inflammatory mediators that alter peripheral cells that may cross the blood-brain barrier and cause neuroinflammation, contributing to neurodegeneration and Alzheimer pathology, and that certain organisms are more harmful than others and some are helpful, and therefore by administering probiotics or prebiotics we may be able to alter. There were a few posters presented at the CTAD, but still nothing with a silver bullet type data. So what are the conclusions? Amyloid antibodies are on the forefront. They may have breached experimental clinical boundaries, but certainly not ready for widespread use yet, of interest, and we need to get together and think about how to put this opportunity that is arising for our Alzheimer's patients in a way that benefits those that may benefit from it and protect those that won't. GLP-1 agonists, HMTM, ASMs, anti-seizure medications, statins are some of the notable promising agents. Brain network therapeutics and stem cells are frontiers of investigation, really not ready for prime use. We don't have data for those. And perhaps the most important thing is that local data in Saudi Arabia are sorely needed, and collaborative work is sorely needed. Over the past couple of years, under the Saudi Neurology Society, we established the Saudi chapter of Cognitive and Behavioral Neurology, which I humbly and I'm honored to preside over, not for too long. Someone has to be listening to me. And we have had our conference, and we had excellent conversations, and we really look forward to working with everybody. It's always, big things are always achieved with collaboration, and we're very welcoming to that. Thank you very much for the invitation and for listening.
Thank you very much, Dr. Heytham, for this really informative lecture. We will keep the question by the end of the session.